So for this part of the module, we're going to review questions that pertain to the case study and overall can be generalized to different patients you can see in the pre-hospital setting. And overall, this reviews the basic life support standards and our medical directives and just the nuances in it. So for the first question, how should we ventilate intentional pneumothorax? So this one's interesting. In the basic life support standards, it does specify that if we do have to ventilate them, we should do it at a reduced rate and reduced volume. Because obviously if we vigorously ventilate them, meaning we give them excessive amounts of breaths or excessive force, so you're increasing the volume in their chest that cannot leave in the pleural space because it's that one-way valve effect, and that can increase the intrathoracic pressure and overall exacerbate their pathology. And that could lead to cardiorespiratory arrest. So we should do ventilations at a reduced rate and reduced volume to minimize that risk, but overall apply sufficient amount of oxygenation. If you look at some research, they do specify that if patients are spontaneously breathing and they look like they're having normal amounts of oxygenation, maybe we should just apply an NRB instead of ventilations, because that could exacerbate the underlying damage. But again, if they need ventilations, just reduced rate and reduced volume. So what bullet characteristics relate to its damage? So this one's interesting. Obviously, the major kind of sites that get damaged from bullets in the civilian population is like extremities, but also it can affect the head, the chest, the back, and all these other areas of our body. They can cause significant damage depending on the gun that's used, how many bullets, where did it hit, how far did the bullet travel. All these aspects matter. And the most common gun utilized in Canada is a handgun. And usually it's related from suicide, which is quite sad. And if you look in comparison to the rates, suicide is the number one cause, and it's twice as likely to occur in comparison to homicides. Obviously, we don't have the same problem as our neighbors to the south with gun-related violence, but if you look, gun-related violence has actually increased steadily over the past couple of years, since 2016 to 2020. And again, suicide is the number one cause, and obviously it has a case fatality rate in the 90s, because if they shoot themselves in the head, obviously that can cause catastrophic damage. But most bullets are actually made of lead, which is quite interesting. So you have the rim, you have the propellant in it, and if they don't die initially from the damage, they could potentially get lead poisoning further on. So you can see this can lead to subsequent serious damage. And bullets, they can cause severe damage to our tissues, our muscles, our vessels, our bones. It can cause severe pain. It can cause significant hemorrhage. And overall, bullets don't travel in a straight trajectory. They can hit bones and they can ricochet. They can go elsewhere in the body, and it's very unpredictable. So that's why there's so many different factors that can play. Because again, how far did the bullet get fired in comparison to the patient? Because the closer they are, more significant damage that could potentially occur. Did it go straight through? Was there an entrance and an exit wound? That matters as well. And bullets are available in a wide variety of sizes, shapes, density, that all affects their flight pattern, penetration capabilities, and wounding potential. Because if we look, like guns can be classified as high velocity weapons or low velocity weapons. High velocities are like rifles. Those travel at 2,000 feet per second or faster. So that's a significant amount of force and damage just from the inherent speed of bullets. But low velocity weapons, even though just a name, they travel less than 2,000 feet per second, but of course they're traveling absurdly quick. And those are from like handguns and pistols. A shotgun, obviously that can lead to major damage. But those travel at 1,000 to 1,500 feet per second. But shotguns have those pellets in the shell, so they disperse out, and these can lead to just chaos of damage inside of them. So that's why the bullet and the type of gun that was fired truly matters. And bullets can either be retained inside the patient's body or they can leave it. And if you look, so if bullets go right through the patient, that means that less amount of kinetic energy was actually distributed to the patient. So the bullets in retain, that means you have a significant amount of like kinetic energy and force just dispersing throughout their bodies. So that leads to a higher risk of internal damage, which is so problematic. And bullets can create permanent cavities as well as temporary cavities. So just from the bullet traveling through the body, from the shearing and compression forces, this leads to a low permanent cavity, and around that is the temporary cavity, and this is just from this high energy pressure vibrations from the projectile's trail that creates this temporary cavity. And if a bullet penetrates skeletal muscle, it's more prone to permanent cavitation, because again, bullets from gunshot wounds, the amount of damage that is exerted depends on the kinetic energy, which is dictated on the page or the bullet's caliber, the distance travel, its entrance profile, and the tissue that it was impacted. Does determining what is an exit versus entrance wound matter? So we look at our basic life support standards currently. If it hits the patient in the back or the chest, it does recommend trying to ascertaining which one's an entrance wound or what's an exit wound. However, research has demonstrated it's very hard to distinguish, and it truly doesn't matter in the grand scheme of things. They have holes where there shouldn't be holes, and overall, depending on the proximity and location of the body, it's like, did the bullet potentially hit, or bullets? And that's what truly matters. They have holes where there shouldn't be. But if we want to kind of determine which one's more likely to be an exit versus an entrance wound, exit wounds tend to be larger, and they're usually non-deforming, especially if the gun is fired at a close range, or if the bullet encounters tissue that is minimal in thickness or density, so they're really not deforming. But if bullets are traveled at close proximity to the patient, you can see like soot actually accumulate on the entrance wound. That's why you can see burn marks. So it's kind of like a point blank kind of bullet, like assassination. So what are the benefits of a hemostatic agent? So we look, most in-hospital deaths from uncontrolled hemorrhage usually occur in the first hour. However, if hemostatic agents are applied in the pre-hospital setting, you dramatically improve patients' survivability. So they are potentially life-saving measures. And if you look at our basic life support standards, hemostatic agents can be beneficial and used for those patients experiencing uncontrolled hemorrhage in the junctional areas where tourniquets obviously can't be applied, such as the head, the trunk, the groin, all those different areas. And if the wound is in a hollow space, such as the abdomen, the skull, or the chest, we can apply the manual pressure of a flat palm and a hemostatic agent, but we don't pack or we don't put our digits into those holes, obviously. And there's 3 different types. You can have combat gauze, you can have HemCon, and Cellux, and they all have good evidence to support their clinical effectiveness. However, there hasn't been a determination of which product is superior over the other. And if you look how they actually work, the main mechanism for clotting is that it absorbs this water and it causes this rapid concentration of platelets and clotting factors that lead to rapid clot formation. And once the quick clot, like especially if that's the type, the quick clot expands, it can take the shape of the receptacle that it's placed in. And the self-expanding hemostatic polymer acts through 2 mechanisms to control the hemorrhage because of rapid swelling followed blood absorption, which leads. So how do we treat this patient's left thigh injury? So obviously this patient's having an uncontrolled hemorrhage to the left thigh. And again, if you tear or damage your femoral artery, you can lose up to 1 liter of blood alone, which puts you at high risk for shock, which indicates that you have inadequate removal of metabolic waste and insufficient perfusion, which is obviously problematic. And if you look, tourniquets are life-saving interventions. Like they dramatically reduce morbidity, mortality, and prevent hemorrhage and can stop hemorrhage that is uncontrollable. And the early application of them in the pre-hospital setting does so much benefits. And there's very minor adverse events with it. But again, it's this direct tamponade effect. So they're very beneficial devices. Once it's on, leave it on. If it's still uncontrolled with the application of a tourniquet, we can always apply a second one if it's needed and warranted. And that's why you can use a combination of a hemostatic agent as well. Overall, they can prevent and treat that non-controllable hemorrhage and dramatically save patients' lives. Is this patient indicated for cervical collar? So obviously, if patients get shot in close proximity to their spine, or bullets can just ricochet in precarious patterns. But the patient did get shot in the back. So that's obviously close proximity to their spine. And approximately 13 to 70% of cervical spine injuries are related to gunshot wounds. So it's a pretty fair chance you could damage the bullets could damage their cervical spine. Obviously, the initial damage is the initial damage. That's the primary injury that could lead to a transection of their spine, and we can't prevent or treat that. However, we can minimize and treat the secondary injuries, which are caused by inflammation, ischemia, and all these other pathological mechanisms. And we just want to stabilize and maintain that neutral alignment to prevent any subsequent damage. So that's why we apply the cervical collar, and they could be beneficial. However, again, cervical collars can make airway management a little harder and difficult, but the benefit outweighs the risk. But again, we just have to be aware there could be underlying cervical spine injuries. And again, once we apply it, it could lead to kind of impairment of ABC management. So is this patient indicated for a needle thoracostomy? So this applies to ACPs, but it's always beneficial for PCPs and PCP-IVs to review this so we can work together. And under current medical directives, ACPs can administer a needle thoracostomy for those that are in cardiac arrest or pre-arrest, demonstrating signs of hypotension, and they have to have diminished breath sounds on the affected side or absent breath sounds. The patch point was removed for this because obviously it's potentially a life-saving procedure and it needs to be done in a timely fashion. Obviously, if patients don't meet the exact medical directives, we always patch it. They believe they would benefit from it. For adults, you can use two sites. The fourth intercostal space, anterior axillary site, is the preferred site. It has a higher success rate, lower complications, and the second intercostal space, mid-clavicular line, can be used still, depending on patient's injuries, logistics, or why. But again, if you look at studies, and a lot of these studies have to be done in like cadavers or radiographic studies, it's hard to do a randomized controlled trial of it. But failure rates for the second intercostal space, mid-clavicular line, is approximately 5 to 40% in some studies, which is quite staggering. And the main reasons is because inadequate needle depth and large chest cavity and just inadequate actual needle location that it was performed on. But now that we know that, you at least need a 5 centimeter needle to reach the pleural space. However, that's what led to the potentially 5 to 40% of failure rates. And that's why under the Ontario paramedic equipment standards, it recommends at minimum a 6.35 centimeter needle to actually reach the pleural space, because that's what we have to do to alleviate the pressure to hit that spot. So that's why it's recommended. However, we look at pediatrics. In our catchment area, it's recommended one site, which is the fourth intercostal anterior axillary site. That has, again, higher success rate, lower complications, lower chest cavity size at a time, so it leads to a higher success rate. Especially in younger pediatrics, the thymus and the great vessels are in close proximity to the second intercostal space, mid-clavicular line. That's why it's not recommended, because it could lead to a risk of iatrogenic air and injuries. So that paramedics have been asking, what if you physically can't landmark the fourth intercostal space, anterior axillary site? That's a very rare circumstance, because we can still do it within the diamond in the area. But it's recommended, if truly like 1 in a million chance you can't do this, just do a blind insertion. Try to landmark the best you can. And if you hit the rib, just walk above it to avoid the neurovascular bundle. And you know there's an intercostal space there, so you will eventually hit it. That is the recommendation. And overall, needle thoracostomies have reduced mortality in the first 24 hours of in-hospital admission, especially if they're done as soon as possible in the pre-hospital site. So again, potentially life-saving interventions. So what are the benefits of calling orange or transporting to the trauma center of this patient? We've obviously reviewed this many times, and this is why the orange criteria is in place, for the field trauma triage guidelines are in place, and this is applicable to any of our services in the catchment area. Whether they're up north, they could rely on the helicopter response, or just if you need to get the patient to the trauma center in a timely manner. Because trauma is always almost surgical in nature. They need some more higher level of care and definitive care that we may not be able to give in the pre-hospital setting. Because we can stabilize them, hopefully, but they need surgical emergencies. That's why studies have demonstrated the sooner you get them to the trauma centers, the higher likelihood they will survive and the better outcomes they have. Because they've compared land transports in comparison to helicopter responses. Those that did land transports, obviously that probably takes longer in nature to get there, and that has higher complications, higher hospital admissions, higher ICU admissions, more complicated treatment plans, and so many factors. So that's why it's beneficial to get patients to the trauma center if they indicate it. Because obviously this patient meets it. It's truly a surgical emergency. They have numerous different pathologies going on, and they need higher levels of definitive care. Would this patient benefit from a fluid bolus? So, large amounts of fluid in trauma is a potentially contentious topic. However, the research is pretty clear at this point that the more fluid you give the patient in trauma, the kind of worse outcomes they have. Because obviously we don't bleed out normal saline. That wouldn't make sense. Normal saline has no oxygen carrying capacity. It's an acidotic fluid. It has a pH of 5.5, and these patients are going to be acidotic. It can lead to hyperchloremic acidosis, which obviously exacerbates or clotting and overall exacerbates the lethal trauma triad. Could normal saline or fluid bolus be beneficial? So it's an isotonic fluid, which means it distributes equally in our vasculature, but only 33% of it stays in the vasculature approximately, or it gets distributed into the other compartments. But that's why higher levels of normal saline administered could lead to and exacerbate tissue edema. And it could disrupt our clotting factors. It could exacerbate hypothermia, which overall impairs our ability to clot. So now we have this impaired ability to clot. We're making ourselves more acidotic. We could exacerbate the hypothermia even more. And all this could lead to an increased mortality. That's why they're showing signs of poor perfusion, such as cyanosis, altered mental status, reduced MAP, or mean arterial pressure, which our monitors give to us. It's one of the numbers that calibrates it, so you don't have to do the funny equation on the scene. The number's given to you. If they have a perfusion or a mean arterial pressure of at least 65, you know they're perfusing their vital organs. So if a patient's blood pressure is like 86 on 50, but their MAP comes back at 66 from the monitor, you can say, I want to refrain from giving normal saline at this point in time, even though they may meet the directive, because you don't want to cause all this subsequent damage. As long as they're perfusing their vital organs, that could be beneficial. Permissive hypotension is obviously a pretty famous topic. They haven't really established the direct blood pressure or systolic blood pressure. A lot of sources say between 80 and 90, because they'll still have a mean arterial pressure, hopefully about 65, depending on the circumstances. But they haven't had like an exact number to strive for. But overall, that's why the mean arterial pressure is kind of the number that we want to hit, is at least 65 to perfuse their vital organs. But again, larger amounts of fluid administration in trauma leads to worse outcomes. We just want to restore enough preload to help perfuse their vital organs.